Welcome. In this session, we are going to discuss how to approach an uveitis patient and to establish as accurate a diagnosis as possible in that patient. So, uveitis is primarily an inflammation of the uvea, and the uvea consists of the choroid, ciliary body, and the iris. However, this inflammation of the uvea may be associated with inflammation of adjacent structures, which may be the vitreous, the retina, the sclera, optic nerve, and cornea. And etiologically, we primarily have two broad groups of uveitis: infectious uveitis and non-infectious uveitis. Non-infectious uveitis are considered to be autoimmune in nature, and they may be associated with systemic diseases. Classification of uveitis and description of the uveitis in a patient is very important to generate a differential diagnosis, and generating a differential diagnosis is the key in managing uveitis. Classification and description of uveitis can be by anatomical involvement, onset of the disease, duration of the disease, course of the disease, activity of the disease, laterality of the disease, and whether the disease is non-granulomatous or granulomatous. In 2003, the standardization of uveitis nomenclature was published, and it primarily described the anatomical classification of uveitis, which is now internationally accepted. And ACUN has classified uveitis as anterior uveitis, intermediate uveitis, posterior uveitis, and panuveitis. In anterior uveitis, anterior chamber is the primary site of involvement, and it comprises of the entities iritis, iridocyclitis, and anterior cyclitis. Cyclitis is inflammation of the ciliary body. In intermediate uveitis, vitreous is the primary site of involvement, and it includes the entities hyalitis, that is inflammation of the vitreous itself, pars planitis, and posterior cyclitis. In posterior uveitis, the choroid and or the retina are the primary sites of involvement, and it includes entities such as choroiditis, retinitis, chorioretinitis, and retinochoroiditis. In chorioretinitis, choroid is involved more than the retina, and in retinochoroiditis, the retina is involved more than the choroid, and neuroretinitis. In panuveitis, the anterior, the intermediate, and the posterior segments are involved almost to similar extents. When the onset is considered, the disease can be sudden in onset or insidious in onset. When duration is considered, the disease can be limited when it is less than 3 months in total duration, or persistent when it is more than 3 months in total duration. And when the course of the disease is considered, it is called acute when the onset is sudden and the duration is limited. It is called recurrent when there are 2 or more episodes separated by treatment-free intervals of more than 3 months. And it is said to be chronic when episodes are separated by treatment-free intervals of less than 3 months. And based on disease activity, the disease is said to be inactive when there are grade 0 cells in anterior chamber. We'll come to cellular grading a little later in this session. The disease is said to be worsening in activity when there is a 2-step increase in the grading of AC cells or vitreous haze, or increase in the grading of AC cells or vitreous haze from grade 3+ to grade 4+. The activity of the disease is said to have reduced or improved when there is a 2-step decrease in the grading of anterior chamber cells or vitreous haze, or a decrease of the grading of anterior chamber cells or vitreous haze to 0. Remission is said to be inactivity persisting for more than 3 months after discontinuation of the treatment. So a chronic uveitis by definition does not undergo remission, while a recurrent disease can undergo remission by definition. It is important to consider whether the disease is unilateral or bilateral for developing a differential diagnosis. Determining the type of inflammation is also important to narrow down our differential diagnosis, and the type of inflammation can be either non-granulomatous or granulomatous. These two types can be defined either histologically or clinically, and the clinical definition is more important for our purposes. In the non-granulomatous inflammation, histologically we find predominantly lymphocytic and plasma cell infiltrate, and clinically we find fine capes or keratic precipitates distributed diffusely on the entire endothelium. In a granulomatous inflammation, By definition, we find epithelioid and giant cells histologically in addition to lymphocytic and plasma cell infiltrates. And clinically, we find mutton fat capes which are large and greasy in appearance on the inferior portion of the endothelium. In granulomatous inflammation, we can also find solitary granulomas in entities like sarcoidosis and tuberculosis, or we may have a diffuse granulomatous inflammation such as in Vogt-Koyanagi-Harada syndromes and sympathetic ophthalmia. The granulomatous inflammation can also be a localized entity such as in lens-induced uveitis following rupture of the lens capsule. However, we must remember that the clinical nature of the inflammation and the histological features of the inflammation may not match, and we are more interested in the clinical description of the type of inflammation. Retinal vasculitis is an inflammation of the blood vessels of the retina. However, it is not considered during anatomical classification of an uveitis entity. Here we can see the severe perivascular pattern of inflammatory exudation. However, perivascular inflammation can also be much more subtle and difficult to detect. And there are entities like acute retinal necrosis, in which primarily the arteries are inflamed, and entities like Ehl's disease, in which primarily the veins are involved. And there are entities in which both arteries and veins are involved to a similar extent, such as in frosted branch angiitis. This is probably the most important slide in this session. And as we have mentioned, development of a differential diagnosis is key to accurately diagnosing an uveitis presentation. What is important is that the development of differential diagnosis follows complete description of the uveitis as to the history of the disease, the ocular examination findings, and the physical examination findings. And only after development of the differential diagnosis, we do laboratory tests and ocular imaging directed to our shortened list of differential diagnosis. Points to be considered when taking the history of a patient are age, race and sex of the patient, ocular symptomatology like the onset of the disease, the duration, the laterality and the associated symptoms like blurring of vision, pain, photophobia and floaters, history of ocular treatment received if any, presence of any known systemic diseases such as autoimmune diseases, infections, immunocompromised status and their treatment history if any, history of trauma and surgery which can be either ocular or systemic, history of hospital admission and intravenous therapy as well as intravenous drug use which also includes drug abuse, occupational history, tobacco use, eating habits, exposure to pets and sexual practices, and family history of a similar disease entity. And although as ophthalmologists we are not expected to examine the non-ocular systems, however, we are expected to take history of symptoms of the non-ocular systems such as fever, weight loss, malaise, night sweats, musculoskeletal symptoms such as arthralgias, joint stiffness and lower back pain, dermatological symptoms such as rashes, sores, alopecia, poliosis and vitiligo, neurological symptoms such as tinnitus, headache, meningism, paresthesias, paresis and altered mental status, respiratory symptoms such as shortness of breath, cough with or without sputum production, gastrointestinal symptoms such as diarrhea, bloody stools and oral aphthous ulcers, urinary symptoms such as sores, dysuria, discharge and pain. We will be discussing the relevance of these symptoms and of the points in the history we should take when we will be considering the individual disease entities. Now coming to ocular features of uveitis, and the ocular symptoms of uveitis are distinctly different in different anatomical patterns of uveitis. Acute anterior uveitis usually presents with pain and photophobia. The photophobia and the pain is because of ciliary spasm, and photophobia is a very important symptom which may enable us to differentiate very early onset acute anterior uveitis from other conditions such as conjunctivitis. And other symptoms of acute anterior uveitis includes redness and blurred vision. The blurring of vision is usually mild if there is no significant cataract and is usually due to fibrin in the anterior chamber. In chronic anterior uveitis, the patient usually complains of blurred vision but does not complain of pain or redness, and the blurring of vision in chronic anterior uveitis can be due to cataract, band keratopathy, or macular edema, which are all complications of long-standing inflammation. Patients with intermediate uveitis typically complain of floaters. They may also complain of blurred vision when they develop macular edema, cataract, or significant vitreous haze, but they usually do not have any pain or redness. In posterior uveitis, we also get floaters from associated vitritis, but more importantly, we get blurring of vision because of the retinitis and or choroiditis, vitreous haze, cataract, or macular edema. In panuveitis, since all anatomical portions of the eye is involved, any combination of the above symptoms can be the presenting features. We will describe ocular signs of uveitis as may be present in the anterior segment, the intermediate segment, and in the posterior segment. In the anterior segment, starting with the lid, we may find depigmentation of eyelid skin and eyelashes in Vogt-Koyanagi-Haradas syndrome. In the conjunctiva, we will get ciliary congestion in acute anterior uveitis. In the cornea, we may get herpetic lesions in herpetic keratouveitis and band keratopathy as a complication of chronic uveitis. So this picture shows ciliary congestion in acute anterior uveitis. As we have discussed, keratic precipitates can be non-granulomatous in type or granulomatous in type. The non-granulomatous keratic precipitates, if they are fresh, they are small, round and white in color, and later on they become shrunken or crenated and glassy or pigmented in appearance. Granulomatous keratic precipitates or mutton fat keratic precipitates, as we have described, are large, yellow and greasy in appearance. And keratic precipitates, particularly the mutton fat keratic precipitates, are distributed in an wedge area of the inferior corneal endothelium called the Earl's triangle. However, KPs are classically described to be distributed diffusely over the entire endothelium in two entities, Fuchs' uveitis syndrome or Fuchs' heterochromic cyclitis and herpetic keratouveitis. Cells in the anterior chamber in uveitis are actually leukocytes or white blood cells, and they are graded by counting the cells in a high intensity 1 by 1 mm slit projected from a 45 to 60 degree angle. And if you find less than one cell in 1 mm by 1 mm slit, it is graded as 0. If you can count 1 to 5 cells, it is 0.5 plus, between 6 and 15 cells, 1 plus, 16 and 25, 2 plus, 26 to 50, 3 plus, and more than 50, 4 plus, and hypopyon can be present in severe uveitis. Aqueous flare is the visibility of the slit lamp beam in the anterior chamber, and this is very important to understand. When the slit lamp beam is thrown into the eye, it passes from the cornea to the iris after passing through the aqueous humor. Normally, in a quiet eye without anterior uveitis, this portion of the slit lamp beam within the aqueous humor is not visible and appears dark. But if this portion of the slit lamp beam is visible, then we say that aqueous flare is present. And aqueous flare occurs due to leakage of protein through inflamed blood ocular barrier. So aqueous cells are leukocytes, and aqueous flare occurs due to leakage of protein. And aqueous flare is graded as invisible if this portion of the slit lamp beam is dark. If this portion of the slit lamp beam is only faintly visible, we say that the aqueous flare is faint or is 1 plus. If this portion of the slit lamp beam is clearly visible but still the iris details can be clearly made out, the aqueous flare is graded as 2 plus or moderate. If iris details cannot be made out clearly through significant aqueous flare, then the aqueous flare is said to be severe or 3 plus. And if we find fibrin in the anterior chamber, we grade it as 4 plus or intense flare. So here we find fibrin in the anterior chamber. In the iris, we may get posterior synechia and peripheral anterior synechia. We may get iris nodules. Iris nodules in the pupillary margin, in the stroma and in the angle have their own names. In Fuchs' uveitis, we find heterochromia and a moth-eaten iris, and in herpetic uveitis, we may find stromal atrophy of the iris. This is a patient with herpetic keratouveitis. We find the involvement of the cornea here and stromal atrophy in patches in the iris. Intraocular pressure in a patient with uveitis can be either low or high. We get a low intraocular pressure either due to reduced production of the aqueous humor due to ciliary body inflammation, ciliary body detachment, or atrophy. And increased uveoscleral outflow in uveitis can also reduce the intraocular pressure. Intraocular pressure can increase if there is blockage of the trabecular meshwork by inflammatory cells and debris. Because of inflammation of the trabecular meshwork itself called trabeculitis, because of peripheral anterior synecdoche, pupillary block, and corticosteroid therapy. Here we find a patient with significant anterior uveitis with hypopyon, and there is 360 degrees posterior synechia, as a result of which there is peripheral bulging of the iris anteriorly, which can be made out in this photograph, and this is called iris bombil. And this further leads to development of peripheral anterior synechia and blockage of aqueous drainage through the trabecular meshwork. In the crystalline lens, we may find capsular disruption in post-traumatic uveitis called phacoanaphylactic uveitis. In post-surgical uveitis, we may find retained lens particles. We may find malposition intraocular lens in uveitis glaucoma high fever syndrome. And cataract develops in chronic and recurrent uveitis, which is usually posterior subcapsular in nature to begin with. Signs in the vitreous cavity or the intermediate segment can be vitreous cells analogous to cells in the anterior chamber and vitreous haze analogous to aqueous flare. In anterior uveitis, vitreous cells are present in the anterior vitreous only, and vitreous cells are found throughout the vitreous in intermediate, posterior and panuveitis. To detect and grade vitreous cells, the retrolental space is evaluated with a 1 mm by 0.5 mm high intensity slit lamp beam through dilated pupil. And if you find less than one cell in a slit of 1 mm by 0.5 mm, then the vitreous cell grading is said to be 0. Between 1 and 5 cells it is 0.5, 6 and 10 it is 1 plus, 11 to 20 2 plus, 20 to 53 plus, and more than 54 plus. Here we can see that the anterior vitreous cells appear as punctate white dots just behind the crystalline lens. By consensus, vitreous cells if attached to vitreous strands are considered as old, and those not attached and those which are free are considered as fresh vitreous cells. And we must remember that grading of vitreous cells has not been endorsed by the standard uveitis nomenclature system, while grading of anterior chamber cells, anterior chamber flare and vitreous haze has been endorsed by SUN. The vitreous haze is based on clarity of view of the posterior segment during ophthalmoscopy, usually indirect ophthalmoscopy. And the grading had been developed by NIH and has been adopted by SUN, as I have just mentioned, and should be done through dilated pupil. If the view of the fundus is clear, then vitreous haze is absent or its grade is 0. Presence of faint haze is graded as 1 plus when it doesn't obscure the view of the disc and the first order retinal vessels. Grade is said to be 2 plus when it is moderate but disc and first order retinal vessels are still visible. The grade is said to be 3 plus when there is marked haze but the disc is visible while first order retinal vessels are not seen. In grade 4 plus, there is intense haze and disc and the first order retinal vessels are not seen. And as we have mentioned, a two-step improvement in vitreous haze indicates a definite reduction in activity of the disease process in the vitreous cavity. Apart from vitreous cells and vitreous haze, in the intermediate segment we may find snowballs, which are clumps of cells within the vitreous cavity, or snow banking, which are exudates over the pars plana, most prominent inferiorly. And intermediate uveitis is termed as pars planitis only when we find this snow banking. When active, the snow banking appears fluffy, and when inactive, it appears smooth and fibrotic. Signs in the posterior segment in posterior uveitis can be choroiditis or retinitis. Involvement in choroiditis appears to be deeper to the retina with overlying retinal vessels spared. And in retinitis, the inflammation is very superficial. Here we find an adjacent scar and the likely diagnosis is toxoplasmosis. And these choroidal and retinal infiltrates can be unifocal, multifocal or diffuse. Vasculitis may also be found, and vasculitis is peripheral in intermediate uveitis, but is usually posterior in posterior and panuveitis. In the posterior segment, we may also find complications of posterior or panuveitis such as swelling of the optic nerve, retina and choroid, or their atrophy, retinal detachment. Here we find an exudative retinal detachment where the fluid accumulation is gravity dependent. We may get pre-retinal or subretinal fibrosis and retinal or choroidal neovascularization. This picture shows neuroretinitis, an optic nerve inflammation associated with a macular star of hard exudates in a perifoveal distribution. All uveitis patients ideally should undergo a systemic examination, preferably by an internist. Generating a list of differential diagnosis is the key to the management of an uveitis patient. So before we generate a differential diagnosis, we first describe the disease entity comprehensively with the help of history, ocular examination and findings in physical examination. An example of a comprehensive description is bilateral panuveitis in a 40-year-old female with a history of ocular trauma 5 years back with mutton fat keratic precipitates, fundus depigmentation with discrete atrophic spots. And this type of a comprehensive description is very helpful in generating a list of differential diagnosis. However, you must remember that typical clinical features of a known uveitis entity may not be present in the initial presentation of a patient and only develop later with time. And as a result, with the passage of time, our differential diagnosis or our final diagnosis may change. And after comprehensive description of the disease entity, including the findings from the history, the ocular examination and the physical examination, the differential diagnosis is developed by a method called naming and meshing, in which we attempt to match the features in the comprehensive description of the uveitis presentation in an uveitis patient with a list of known uveitis entities having similar clinical features. And only after a list of differential diagnosis has been generated with the use of naming and meshing method, only selective systemic and ocular tests are ordered. If the investigations ordered do not match the clinical features of the patient, the investigations may actually misguide us, and the selective systemic and ocular tests are directed towards possible etiologies of uveitis, which includes infectious uveitis, and the infection can be a local infection or a systemic infection, autoimmune uveitis or non-infectious uveitis, and when relevant, we should also rule out masquerade syndromes, which are not actually inflammatory but present with features similar to uveitis. And the masquerade syndromes can be either neoplastic or non-neoplastic. There is no one standard battery of tests which is ideal for all uveitis patients, and the tests are only directed towards the list of differential diagnosis generated after comprehensive description of the uveitis entity. Having said that, routine investigations are done by almost all uveitis specialists directed towards entities which can present as any anatomical pattern of uveitis, and among them we have syphilis, for which we must do serology such as VDRL and FTA-ABS, tuberculosis, for which we may do PPD or Montrose test, and interferon gamma release assay or quantiferon gold test. Chest radiograph is also done routinely by most uveitis specialists to rule out tuberculosis and sarcoidosis, which can manifest as any pattern of uveitis. However, it is important to remember that acute unilateral non-granulomatous anterior uveitis does not need routine investigation, so it has to be acute unilateral and non-granulomatous anterior uveitis. And apart from this well-defined presentation, most uveitis specialists do these routine investigations for all other presentations of uveitis, and as we have mentioned, other tests are done as directed by the differential diagnosis generated. Now coming to ophthalmic investigations, they are important both for aiding diagnosis and monitoring response to therapy, and among them we have optical coherence tomography, which may detect macular edema, and or retinal thickening, choroidal neovascularization, subretinal fluid, choroidal thickening, particularly with the enhanced depth imaging mode of OCT, and ACE OCT may help us in detecting retained dense fragments and malpositioned IOLs. Fundus fluorescent angiography may help us to detect retinal, choroidal and optic nerve inflammatory lesions, retinal vasculitis, retinal perfusion abnormalities, macular edema and choroidal neovascularization. Here we see an uveitis called serpiginous choroiditis, and in the early FFA we get hypofluorescence, whereas in late FFA we get stippled hyperfluorescence. Here we see retinal vasculitis with the typical leakage in FFA, and this shows the petaloid pattern of CME in the late phase of fundus fluorescent angiography. Indocyanin green angiography is useful in inflammatory chorioretinopathies such as white dot syndromes, VKH and sympathetic ophthalmia, and for evaluation of choroidal perfusion and neovascularization. And in the fundus autofluorescence technique, we find increase in autofluorescence with increase of disease activity and decrease of autofluorescence with disease remission. With B-scan ultrasound, we may find vitritis, choroidal thickening, retinal detachment, intraocular foreign bodies and posterior scleritis. This picture shows choroidal thickening, and in this we see both choroidal thickening and the typical T sign of posterior scleritis. With ultrasound biomicroscopy, we can reveal abnormalities in the iris, ciliary body angle and malpositioned intraocular lenses. Electrophysiology, particularly full-field electroretinography, can be helpful in detecting and monitoring of acute zonal outer ocal retinopathy and related diseases, birdshot chorioretinopathy and autoimmune retinopathy. And visual fields are also important in monitoring azure and related diseases, birdshot chorioretinopathy and autoimmune retinopathy. Visual fields are also important for monitoring uveitic glaucoma and involvement of optic nerve by inflammation, and central visual fields can be important for white dot syndromes such as punctate inner chorioretinopathy. Polymerase chain reaction of aqueous and vitreous tab can be useful for infections as well as neoplasms such as lymphoma. Aqueous tab is safer than vitreous tab, and it has been found that aqueous tab has significant diagnostic value for infectious posterior uveitis such as herpes simplex virus, varicella zoster virus, cytomegalovirus and toxoplasmosis. Highly conserved pan-bacterial and pan-fungal antigens can also be detected with PCR. PCR is also useful for detecting intraocular lymphoma. However, the diagnostic yield of an aqueous tab for viral anterior uveitis is low. We have discussed the Goldman-Whitmer coefficient in the previous session, and it is usually used for toxoplasmosis and viral infections. The fluid in the aqueous or vitreous tab can also be sent for staining and cultured for detecting bacterial and fungal infections. Cytology of aqueous and vitreous tab fluid can be useful in detecting lymphoma and leukemia, and chorioretinal biopsy can detect neoplastic as well as infectious entities. And chorioretinal biopsy being associated with significant risk, it is employed as a last resort for vision-threatening diseases when other less invasive tests have failed to pinpoint the etiology. Conjunctival and scleral biopsy can also be done when we find lesions in these locations. So aqueous tab is done with a 30 gauge needle on an 1 ml syringe, which is introduced through the temporal limbus or the clear cornea parallel to the iris, while avoiding touching the cornea, iris and lens. And approximately 0.1 to 0.2 ml of fluid is aspirated. For a vitreous tab, a 25G needle on a 2 ml syringe is introduced through pars plana and directed towards the mid-vitreous cavity, and vitreous fluid is aspirated under direct visualization if possible. For vitreous biopsy, a vitrectomy setup is required, and 0.5 to 1 ml of undiluted vitreous fluid is aspirated. However, we must remember that half-life of intravitreal steroids is reduced after vitrectomy. Thank you for listening.